A very warm welcome to everybody. You're attending the Young Dementia Network webinar. I'm Tessa Guttridge and I'm chair of the network. And it's a great pleasure today to welcome Maud Ritzen, who's from the Alzheimer Centre Limburg in Netherlands, and Suzanne Heron, Dr. Suzanne Heron, mental health nursing academic at the University of West Scotland. And they are going to take us beyond age appropriate, which is so relevant for young onset. I'm just going to remind you, lovely attendees, that you're not on mic and camera, but that doesn't mean to say we don't want to hear from you. We really do, and we hope you'll use the chat. And please do use the question and answer function. Put questions in the box. Don't pop them in the chat. Pop them into the Q&A box. And do that during this webinar when you think of the questions, rather than leave them to the end, because otherwise we get so many at the end, we can't cover them. We'll protect some time for that. As always, though, we start our webinar with the reality of lived experience. And we're going to start with a conversation between Leanne, whose mother has young onset dementia, and Suzanne. So Catherine's going to start the video now.
All right. Hi, Leanne. Thank you so much for coming on today to give us a little bit of information about your experience with your mum, who I understand is living with young onset dementia, and in particular your experiences of accessing support and services for your mum. I'm sure it'll be really interesting for people to hear your perspective. So I'm just going to turn it over to you and let you lead the conversation. Can you tell us a little bit about your experience then of, firstly living with a young onset dementia, and also of accessing care and support that you feel's appropriate for your mum?
No worries. Well, Suzanne, thank you very much for inviting me along today. I know you've already mentioned my name, but I'm Leanne. My mum has been diagnosed with young onset dementia, or frontemporal. She got diagnosed at the age of 56, which was 8 years ago now. So she lived at home with my dad up until, it'll be 4 years this year. So she's been in a care facility since then. But the process from diagnosis to getting support in the community has been quite challenging. And I know obviously you're very aware of that, but the kind of situation we're facing with my mum was, when she got her formal diagnosis, which had like 3 or 4 consultants involved, it wasn't quite straightforward as I think people that are not in the industry would think. There was initial support from the care centre, where we had carers come out a couple of times a week just to give my dad a bit of respite, get her out and about, still, involved in the community, but having that supervision. That was, I think it was twice a week we got that initially, and that was a hard slog to get that as well. It wasn't, I had to fight or battle constantly, saying she needs a bit of support. And as you're aware, obviously doing all this research, the support for people under the age of 60, 70 is terribly low, and obviously there's not much knowledge behind the illness she has, why she's getting it so young, so the support doesn't match up with what she needs. So it was a good few months of no support, then having just a couple of days, and as I say, it was a constant battle to reach out to the care facility or engage with consultants to try and get a better understanding of what we could do for her, what was in the community to support her. Now, unfortunately, the feedback was always, there's nothing there. There's nothing to support her apart from the care care centre that we were really lucky to get engaged with. And anything that was out there, it was paid support, and unfortunately my parents weren't in the financial situation to be able to do that for her, so we had very limited. We did have social work in place, although there was a high staff movement, so from 1 month to the next it wasn't the same person, which was really challenging as well because you never knew who to speak to. So between probably the age of 56 and 60, that was probably the most challenging part, because the care was very limited, the support was very limited, and then we went into lockdown. So that kind of blew everything out of the water. Just before we hit lockdown, even my mum took a huge dip in her, her mental capacity, and the dementia taking a bit more of a toll on her, which led to her having a stint in hospital where she got assessed with her consultant. So she was in the units at the RH, and it was meant to be initially a 2-month period, but due to lockdown, it turned into 6 months. So during that time, they did obviously a review process, how she's deteriorated, is there anything they can support for her? And that was purely just a medical standpoint. And then the whole, the 56 to 60 range, her medication changed a lot as well as her dementia progressed and her illness took a hold of her. After she did her stint in hospital, we got a bit more support at home. So it went from 2 kind of afternoons to 4, which was really nice. She had built a great rapport with the person that looked after her, so we got her all the time, which was really good. But for my mum, she needs consistency. When there's different people, it kind of throws her off her game. So having that was really, really beneficial for her. Moving forward, maybe if we looked 60 to 62, we started having issues within the community. So when she was out and about, she was maybe having altercations with people. It sadly got to a stage where she had altercations with children, nothing physical, but unfortunately that led her to go back into hospital for another 6 months review. And when she came back out, it was very clear to myself, my dad, and everyone around us that this wasn't going to be a long-term solution, her being in the community, because the incidents were ramping up. The support actually kind of went away as well because of lack of staff within the community to support her. So after all of that, I had decided to put her in a care home. So with the support of the medical staff and social work, we got her a place in a unit in Johnston. Now, the tricky situation with this was meant to be just a 2-week kind of just to cover until we find a more suitable facility. The only facility in Renfrewshire that could take her was out in Renfrew, and they refused to take her due to the physical incident she's had in the past. So my mum has been in the unit in Johnston for 4 years this year, in a unit with people that have Alzheimer's or dementia but are older, like in their 70s right up till their 90s. Now, what I have to say is the care home that looks after her are fantastic. They try their best to support her. One thing to understand about my mum is she doesn't want to do anything. So she's quite a challenging case because she won't go and sit in the recreational room. She won't go out on, days out with the teams and stuff like that. She's very she just does her own thing. So the staff and the home themselves have been fighting to keep her because the home business are trying to get rid of her, but the team at the home are wanting to keep her because, they're so used to her now after nearly 4 years. They've all built such great rapport with her. She's kind of free to kind of go about. They've got her down in a unit which is downstairs, so she can go outside and, just do all the things she wants to do without ever leaving the facility. So a big thing for me and from my perspective is there's not enough support for people that are under a certain age. they don't know kind of what to do with them. They don't know how to support, and that's really clear, especially from starting off this journey nearly 8 years ago. Pardon me. It's very much, you know, they'll give you some things, but there's no funding. There's the care homes that are meant to support people with early onset aren't supporting. You know, there's some reason coming up. My mum's been kind of the violent streak. And then she's putting in a facility that doesn't actually tend to her needs, but because she's a bit more self-sufficient, because she's still semi-aware, she's in a unit basically for all the older people that are a bit easier to manage. A lot of them are bedridden or, you know, in wheelchairs and limited movement. So I think a big takeaway for me being in this experience, being our POA, like trying to figure out what's available for her, being an advocate, is there's not anything there. Like it's as if the government and the local councils don't know what to do with them, so they're just kind of like, oh, we'll see, like a case by case basis. And I suppose some things can be done case by case, but there should be there's something out there for people within that dementia set. You know, what sort of care facilities can we cater just towards them to support them? Obviously, everybody's dementia and Alzheimer's is totally different. They'll go through their journey totally differently, and that's when you kind of need to cater it. But from my perspective, having nothing, it doesn't work, and it's so hard to fight back and just continuously getting told there's nothing there, we can't do anything, or we'll try this, we'll try that. And I know deep down it's not going to work for her, because obviously I know her better than anyone. So, you know, they'll say, oh, we'll take her this place, or we'll give her this medicine, or we'll put her in this facility. You know, I know she's going to fight back. I know how stubborn she is. I know, you know, her needs as well. So it's been quite challenging. I do feel though that the facility she's in are doing the best they possibly can, given the situation, that it's not an ideal place for her. The medical team in the home and the family know ultimately she's going to end up in a hospital, whether that be, you know, Dyke Bar, or I can't remember the other one off the top of my head just now. But she's going to end up in a hospital, which is one of our biggest fears. So we're just hoping that she gets forgetful enough that she doesn't realise where she is, because having to tell her she needs to go into hospital is quite soul destroying. So I keep getting told it is what it is, but something needs to change, because families and the people that are going through it themselves, and even the staff that are supporting, are not equipped to support people and their stage of life with the dementia they've got. Everybody needs support, and a real change needs to be brought about, I think.
Thank you so much, Leanne. That was a really, you know, vulnerable and truthful account and raw account. So I'm sure that it will have given everyone loads to think about today. So thank you so much for agreeing to do it. And I do hope that you manage to get you know, things sorted out as best as you can for your mum.
Thank you very much, Suzanne. It was lovely to speak to you.
Thank you.
So before we move on to Maud, I just wanted to say that if I were a daughter of somebody with young onset, it is what it is, quoted at me, would be devastating. And meeting the challenge of having a parent with young onset dementia, or a partner with young onset dementia, should be enough. Finding the right support should be a given, surely. That's what the network's about, really. Compromise is hard, isn't it, when you're living life? So, but it was good to hear that the sort of consistency and the getting to know Leanne's mother meant so much, and meant that although it wasn't the right place, actually some things could work for a period of time. So thank you very much. Let's hand over to Maud.
Yes, I'm going to share my slides. I think you're all able to see my slides now and to hear me. So yeah, my name is Maud Ritzen and I'm a PhD student at the Alzheimer Centre Limburg. So I'm from the Netherlands. And my PhD is focused on young onset dementia and specifically the psychosocial impact it has on the person living with the condition, but also on the family members. And my project falls under the YOD Included Consortium, where YOD, of course, stands for young onset dementia. And we are a group of researchers all throughout the Netherlands, also with a lot of PhDs, each with their own focus, but everybody focused on young onset dementia. So today I want to tell you something about my research. And the first part of my PhD project, I have done a lot of research onto the needs of persons with dementia and their loved ones. And I'm going to tell you something about it in the next few minutes. So the title of my presentation is No One Size Fits All, Understanding and Responding to Needs in Young Onset Dementia. And I'm going to explain to you why I think that's the case. So before we dive deeper in my research, I want to tell you something a little bit more about the difference, of course, between dementia in general or late onset dementia and young onset dementia. Because also what we could hear from the video that was shown at the beginning of this webinar is that certain support is just not available for young onset dementia, while persons with young onset dementia, they are faced with these challenges in an earlier phase of life compared to late onset dementia, and they just need a different approach and different things. So young onset dementia, of course, was when the diagnosis or the first symptoms occur before the age of 65, so earlier in life. People are often still working, having big financial responsibilities, for example, taking care of your family, getting food on the table, but also paying your mortgage. Could be the case that some people still have children living at home, so younger children or older children who are living on their own, are often engaged actively in social roles. And because of the lack of awareness, actually, regarding young onset dementia, diagnosis often takes years and it's really delayed because also not only the general public but also professionals, they know a lot more about late onset dementia than young onset dementia. So therefore people with young onset dementia, they also tend to have a delayed diagnosis, and also they are stuck in what is going on for a longer period of time, which makes the beginning phase of this disease actually really hard. And there's a lack of age-appropriate services, so services for people for a younger age because they have different needs. I want to conclude on this slide that if the situation is different, of course, the needs are also different. So that really applies to this specific example of young onset dementia. Well, I want to take you with me into the research that I've conducted at the beginning of my PhD, which was focused on exploring the needs. Well, there has been some research already done regarding young onset dementia, but I couldn't find a list of needs that could occur or needs that could occur in different phases, etc. So I dived deeper into the literature and we looked for needs in the broadest sense of the word. So needs that could relate to support, to care, or social needs. We looked it all up. And we also looked not only at the person with young onset dementia, but we also looked at their family members. So it was in the broadest sense of the word, and we found 140 articles that could be included in this review, namely qualitative articles, so where people have been interviewed or focus group sessions have been done. So you really see the kind of stories people tell, and from there you can extract their needs. Well, because 140 articles are a lot, and I have a lot of details, but I cannot cover them all, of course, in this 15 minutes that I have. If you're curious about the details or the full publication, then scan the QR code on the left side of the screen and you will get all the details. I want to tell you something about the 4 main categories of needs that we found. So firstly, we have support needs, we have care needs, interpersonal needs, so needs in relationship to other people, and personal needs, when you really look inside yourself, what do I need at this moment? And those 4 categories, well, they speak for themselves, but I want to give you a little bit of insight into these categories by giving you some examples of the needs that we found. So for support needs, it was really important that there was access to support, being eligible to access some form of support, age-appropriate support, so having the feeling that that support is also targeted at your case and not that you're just entering some form of support that already exists, but it's not really meeting your needs. Local support so that you don't have to travel too long or too much if you need to go somewhere. Feeling welcome, so inclusive, the different cultures, but also people from the LGBTQ community, feeling welcome to access and engage in a specific type of support. And then we also saw that people mentioned that they like to talk to a psychologist just to share their feelings, share their thoughts, but also more practical support and work-related support, because work is also, a big thing that is going on in an earlier stage of life that is also really important, even if you have young onset dementia. We also have care needs, and that actually starts with receiving a diagnosis, knowing what is going on, being able to think ahead and plan your next steps, gaining information about young onset dementia, receiving formal and informal care, being able to collaborate with professionals, trusting them, and also having talks about preferences for care in the future or planning the care for the future, even though that is also a difficult topic to talk about, but it's still really important, and people mention it from themselves that they want to talk about that. Well, the biggest category that we found were like the interpersonal needs. So needs in relation to other people's. So you have here collaboration within the family, as the whole family is impacted, of course, if one person still lives at home. Social contact could be with friends, family members, but also with people in similar situations. Also to share your feelings, to share your thoughts about the situation, but also getting some form of understanding back from others, not feeling weird for being in that situation. Understanding, acceptance by others, being taken seriously, for example, at the beginning phase of the disease where you're still looking for, okay, what is going on? We are noticing this and this and this. I'm worried a little bit. Should I go talk to a doctor or not? If you feel like you're being taken seriously by your friends, your social network, and ultimately by the healthcare professionals, that could really get you somewhere in terms of following the steps to get a diagnosis. And then also awareness regarding young onset dementia in the society, because as I mentioned before, the diagnosis is often delayed because of a lack of awareness regarding young onset dementia. And that makes this difficult situation even more difficult. When looking at oneself, so the personal needs, we have safety, stability, having one's own life was mentioned often by family members, because it can take up a lot of time, of course, to care for your loved one, even if especially if the disease progresses, but you still have your own life and your own things, while you also need to be managing like work things and other obligations. So it's expressed as a need to have one's own life and to do the things for yourself. But in practice, it's really, really difficult to actually do that, because some people might feel that they are, leaving their loved one behind or being selfish if they do that. Meaningful way to spend the day, also really important. Still finding positivity, time for oneself, accepting the situation for yourself, being autonomous and still feel useful. Those are all examples of these categories. And again, if you want more details, then you could scan the QR code on the left for the full publication. After this, we also looked into specific variables to see if needs change in specific circumstances or situations. So we looked into different subtypes. We looked into the living setting of the person with yacht. Is he still living at home, or is he or she living in a care home? And what kind of phase is mentioned in the articles that we have included? Is it before diagnosis, shortly after, or is it the longer term? And how do needs differ related to these specific variables? So to begin with, I want to tell you something about the subtypes, which was actually quite hard to make a distinction in, because a lot of articles have included Alzheimer's disease, or they included multiple people with varying subtypes. So it was really difficult to trace back specific needs to a specific subtype. But what we found was that persons with FTD and PCA, yeah, they often need support with speech and language. And overall, regarding to the different subtypes, people just need subtype specific information, something that is some sort of tailored to their situation based on subtype, so that they know what is going on, what can I expect, and how can I handle the things that are coming my way in the future. Based on living setting, when the person with young onset dementia is still living at home, it is really important, of course, to have some sort of social safety net or social support network to allow the person with yacht to live at home for a longer period of time. And if the person with yacht still lives at home, it could also be the case that this person is still working or still wants to keep working. So it is really important to also have that work-related support and maybe practical support at home, for example, with little sticky notes, or to simplify some actions at home, to still have the feeling that he or she can do the things that he or she wants without handing in too much. So still feeling autonomous and being able to do it. And collaboration within the family is really important in that case, because that's the support network that is surrounding the person with young onset dementia. And living in a care facility, then of course it's a little bit of a different perspective. Family members mentioned that it was really important to have the feeling that they could trust the care professionals, because you want the best for your loved one with young onset dementia, and you don't want to leave him somewhere where you don't feel good about it. So a good connection and trust with care professionals is really important in this case, but also knowing that the person with young onset dementia is safe somewhere, because sometimes it isn't doable anymore for the person to still live at home, also because of safety reasons. For the persons with dementia, they mentioned that contact with peers is really important, and here also comes along the age-appropriate perspective, because often people mention that they do not feel like they fit in with a group if the group is way older than them, that they could not level with them or have like the same experiences or same interests. So it's also really important when living in a care facility that you, ideally, minimally have like one person that is a little bit in your range or with the same interest, etc. So you can connect with that person and share your thoughts and feelings. Lastly, we looked into the phase, and before diagnosis, it's said that people want clarity. They don't know what is going on, but they need it, and they can have it in the form of a diagnosis. Doesn't mean that all problems are solved when a diagnosis has been given, but that next steps can be planned, next things of support can be arranged, and expectations of life maybe can be adjusted. Not to put it in that simple way, but it's giving some sort of clarity to the situation. Shortly after diagnosis, people have a desire for quick access to practical, emotional, work-related support and information. But I think beneath that quick access is the need to know what kind of support is out there, what should I be reaching out for, what do we need, and then being able to reach out to that specific types of support, because people often feel a little bit left on their own. after diagnosis. And then lastly, we have the long term, and then it's more focused on continuity of care, meaningful activities, and balancing own time and care tasks. So, what does all these needs say? Well, at first, it is important to look beyond the individual with YOD because, of course, dementia affects the whole system, especially if the person is still living at home. You need to have some sort of support network around you to be able to live at home for a longer period of time. Well, we saw that needs change over time, so a needs assessment is not a one-time event, but needs to be done regularly. And there cannot be a one-size-fits-all approach in YOD support because services must be adaptable, not static, because needs can change over time. Needs can change in specific situations. People have different priorities in different phases of the disease, etc. But if you understand the needs, that could be a starting point for developing better support or for focusing on support that meets your needs best. And to end this presentation, I have a short example of what we are doing now. We are developing a psychosocial intervention for families living with young onset dementia. And because it's really important and we see that needs vary across different contexts, across the families, across the phases, is that it's really important to include the people you are developing these things for. So by means of co-creation sessions and really having extensive talks with them and seeing what do you need and what can we do for you. Because if you understand the needs, that could be a starting point for developing better support. Well, I would love to give you a lot more details about this, but I think that my time is slowly running up. So I would like to thank you for your attention. If you have questions, put them in the Q&A box. And if you would like to connect with me or see updates around my work, then you could scan the QR code on the left for my LinkedIn. Thank you for your attention.
Thank you so much, Maud. We're going to move straight to Suzanne, but that was a very interesting presentation. Thank you for that, and it'll be really useful. Over to Suzanne. Thank you.
Very good to go to. So thank you very, very much. I'm just going to share my screen. Okay, so hopefully everyone can see that. I'm going to, I suppose, narrow it down a little bit and start actually focusing on one of the things that Maud's been discussing earlier, which is age-appropriate care in young onset dementia. So a little bit about me, just jumping on the Facebook bandwagon and putting up my AI picture. It's pretty accurate and just has the wrong colour of eyes, I think. So my name is Suzanne Heron and I'm a lecturer in mental health nursing at the University of the West of Scotland. I'm also a registered mental health nurse and I've got a background in acute psychiatric care. And my research training is actually in psychology. So I'm a bit of a, I have a foot in two camps, really. I'm very much a mental health nurse, but at the same time, my research background is in psychology. So my postgraduate studies, my PhD was in psychology, not in dementia, funnily enough, but that is where I am currently focused. I'm also an associate member of the Alzheimer Scotland Centre for Policy and Practice at the University of the West of Scotland. I could not tell you anything about my research without mentioning my collaborators. So people that I work with on a regular basis on this topic are Professor Louise Ritchie, Professor Nick Jenkins. So they are both based in UWS. Louise is the director of the Alzheimer Centre for Policy and Practice. Dr. Michael Smith, who is currently at Alzheimer Scotland, and my very first PhD student, Rona Grant, who is doing her PhD in young onset dementia. So my research in young onset dementia has focused around service provision for people living with young onset dementia. And there's some key reasons for that. One of the reasons is actually from my clinical experience that I had before I came back into academia. and decided to change the focus of my research. So when I was in clinical practice, I was in acute psychiatric care, and I came across, I was in secure units or admissions units, and I often had people with young onset dementia who were referred to us for care because there was thought not to be a suitable place to house them at that point, place of safety, often in terms of distress levels and behaviours that staff in traditional residential facilities weren't trained and weren't able to deal with. So I used to see a lot of people coming through, and it always struck me that acute psychiatric care does not seem to be an appropriate environment for people living with young onset dementia. So I was able to talk some people into giving me some funding to look at this, having not really had any experience in dementia research. So I was managed to acquire some funding through the R.S. MacDonald Charitable Trust, and that was administered by the Alzheimer Scotland Centre for Policy and Practice. And I met Louise Ritchie through that, who's been very influential in my research career in dementia so far. So part of the promise, I suppose, for that funding was to do a literature review and thematic synthesis, which we have done, and we're still preparing to submit for publication, but there is a review protocol on Prospero, and that's around about support and care services and what is important to people with young onset dementia, supporters and health and social care professionals, and also why. And it's a bit of a deep dive, again, just as Maud was describing, it's a bit of a deep dive into the literature to, I suppose, set the precedents for my research going forward in this area. And subsequent to that, we carried out a focus group study. Because Maud's already given you some lovely information around about the literature on young onset dementia and care, and it's very related to the review that we did, I didn't think it was sensible really to talk you through all of my review findings, but hopefully it will be published in the future and you'll be able to get hold of that if you're interested. I'm going to actually talk about what's not in the synthesis today, because there were things that we noticed in the data that seemed important but wouldn't have made it into the synthesis, because by its very nature a synthesis takes all of the data from a bunch of other studies, all of the findings and all of the data, and reanalyzes it. So it generalizes it, and it focuses on themes or points of convergence, and that can be sometimes problematic in research because what it doesn't do is provide us with detail and nuance. So some of the things that I noticed that I'd like to bring up is that of 78 studies that were included in our review, only 18 involved professionals. And I think only 9 involved professionals as a group on their own. So actually this perspective, which I think is often assumed to be overrepresented, is actually underrepresented in review findings. Which was surprising to me, because I had assumed that the opposite would probably be the case. And also, as well as synthesizing, we split up the findings for people with young onset dementia, supporters and professionals. So we analysed them separately as well as synthesising them, so putting them all together and drawing generalisations. And what we found when we did that was, for people with young onset dementia, we very much seen those psychosocial factors that Maud was mentioning emphasised, like changing roles, self-perception, personhood, meaning, feeling useful. That came across very, very strongly from that particular group of respondents. For supporters, practical concerns were very much emphasised, which is something that we, I suppose, would expect, given that they're possibly, concerned with all those financial and day-to-day management aspects of living with the condition or supporting a loved one with the condition. And we found that the perspective of professionals was really emphasising barriers and constraints, which for me, coming from a practice background, coming from a clinical background, is really important for realistic service design. So we can talk about what we ideally would like, but we do sometimes need a constraining voice in there as well. So for me, the take home from that is that these three perspectives are all equally important, but they're bringing something unique to the conversation as well that we need to be cognizant of if we are to design services or implement services or frameworks that are actually actionable for professionals who are working in the field and who will be the people who are designing and delivering services. Also, what I'd like to talk about is that the date range for our studies was very inclusive. So it was around about 2001 to 2023. And we found that term age-appropriate care consistently was identified as a service gap or a service need or something that people felt they weren't receiving or would like to receive. And that made me think, well, why is this still a service gap if we have literature that has been saying this for decades? And something else that I notice is the topic of tertiary or residential care, which is very much where I, in my role in acute psychiatry, would have met people with young onset dementia most frequently, is often not discussed in literature around about services. So there were a couple of studies that we looked at that covered that, but actually the vast majority, when people were talking more generally around about service design for young onset dementia, it didn't seem to come up as readily. If it did, it came up in the supporters and professional groups. So that made me think about, I suppose, looking into some of this stuff a little bit in a little bit more depth, so that I could really start to pick apart exactly what is needed in terms of services. And obviously I'm in a Scottish context, so my focus is predominantly around Scotland, but we did look at literature from a diverse geographical range as well. So age appropriate is a term used frequently in the literature in young onset dementia care. And age appropriate care is also a key recommendation of contemporary dementia strategy in Scotland. And that's very much because this dementia strategy would have been evidence informed. Okay, so the important thing about that is that we are taking information from the literature and we're embedding it in policy. And the policy and strategy then needs to be enacted in practice. And that's where I see the gap being. So that's where the remainder of my work probably is going to focus and try and understand. So firstly, what I wanted to do was I wanted to look at the term age appropriate that has come up so many times in the literature, and think about, or have people sit and think about, what does this actually mean, and to see if we could try to develop a shared understanding of that concept. And we've done similar things with other concepts in healthcare. Things like person-centred care have been really widely discussed and studied and defined. So there's no reason for me that we shouldn't do it with something like age appropriateness, especially if we're asking, if that's an ask that we're giving services, is to provide age appropriate care. So questions I had was, is there a shared understanding, or do different groups hold different interpretations? So we looked at people with young onset dementia, supporters and professionals, and we asked them questions. So we did semi-structured focus groups that tried where possible to align the conversation with that concept of age appropriateness, and what were the expectations of services, and what were the understanding was the understanding of that term in these three different groups. Because from the review and from those findings that will not be probably represented in the synthesis that I discussed earlier, what we had noted is that those perspectives might be quite different actually although there's a lot of crossover. They're still unique perspectives. So some of our preliminary findings, and I don't want you to focus too much on this diagram because it looks quite busy. Really what I want to focus in on is the main category here of moving beyond age-appropriate young onset dementia services. And the generic categories here where we're identifying specific aspects of that, like different needs, which Maud's discussed in great length, barriers to accessing services and directions for service design and evidence of good practice. So we had people both identifying and not identifying with the concept of age-appropriate care. So we very much had people that rejected this idea of age appropriateness in favour of a more person-centred or, you know, individual approach. And we had, but at the same time, we had this acknowledgement that there were different needs in young onset dementia, that these could be similar across groups of people, and that there were a lack of services that match age or life stage. So the way I've been thinking about that is it's ambivalence towards the term. I've got an example of a quote that demonstrates this discomfort with the term when we actually start to delve into it. And that's very much used and will be used in the article to demonstrate that main category. And it's from a practitioner, and it's the more I'm thinking of age appropriateness, I'm thinking no. It's a term that I've used personally, and I think the team use it just to highlight things. Our caseload has probably ranged from late 30s to say 65 roughly. That's a huge age range even within what we term younger onset. So yeah, I'm actually very flummoxed. Why am I actually using that term? So that's an example of someone who definitely appears to have a discomfort with that term when they're asked to explain what they think is meant by the term and actually to consider the term. But as I said, overall, I would say there was ambivalence around the term age appropriate, in particular its relationship to person-centred care models. And the way I understand that at the moment, being, you know, still at the point of really looking at this data and trying to work out exactly, you know, what does this mean, is that there are various takes on the relationship with person-centred care and age appropriateness. For some, it's two sides of the same coin. Okay, so it's the same thing. Of course, in person-centred care, we would automatically consider, very much consider individual factors, because as Leanne was saying earlier, you know, the specific needs of her mum might differ from someone of the same age. So using age is possibly far too general. That these are overlapping but distinct, so they're related, but there are features that stand alone between these two concepts, or that they're mutually exclusive. So we, you know, that's that idea of, well, we reject this notion of age appropriateness because we don't find it useful, and it means something completely different from person-centred care. And hopefully, I think a lot of people have their own ideas about how those things relate. I'm certainly not here to tell people what they should be thinking about it. I'm just at the stage where I'm looking into this and I'm investigating it. So there seems to be an acknowledgement that people living with young onset dementia have individual needs, but that age and life stage can help to form a general understanding of the specific difficulties that may be faced. So for me then, to use the term age appropriate may be an oversimplification of what is actually a very complex and nuanced aspect of young onset dementia care. And that's probably the perspective I'll be putting across in the article. In terms of, I suppose, bringing my philosophical meanderings to a close, for thinking about the future of this line of research, I'll be thinking around about concepts that are embedded in best practice guidance and strategy and that appear often in the literature, like age appropriateness, should be clearly defined in order to support service development. So we can't just tell services that they should provide age appropriate care. We need to actually break that down, and we need to fully understand that term and what it means, because that will be defined in multiple different ways depending on the group, or even right down to an individual level, how we define and understand that term. And that research in young onset dementia service provision needs to become more specific and move on from identifying needs to providing depth, clarity, and actionable solutions. Thank you very much for listening.
Thank you, Suzanne. Thank you so much. And age appropriate is an oversimplification, isn't it? And I think your work's going to be really useful. If you stop sharing screen, we'll move to questions and hopefully some consideration of the answers.
Is it unshared now? Like, what's the...
Not yet.
No.
That's it. Perfect. Thank you so much. So, question. It's so hard to take account of the stage of dementia, the type of dementia, the complexity of the disease and the person's age, when you also have to take account of the person's personality too, whether older or younger, really. And the questioner mentions that some people come across as older and some people come across as younger than they actually are anyway. So the question very simply is, how do you do that? And either of you, please have a go at that one.
Well, I could give it a try. Indeed, that's really, really difficult to take into account all those different factors and to ask about all those different things. But I think in general, you can make some assumptions with specific subtypes, persons living at home, etc. But there needs to be a conversation with the person themselves, but also with the family, I think, because they also understand the person really good. So you don't need to have a list with all sort of bullet points and check the boxes with I asked this and this and this. But I think it's a combination of some sort of general understanding and then diving into depth with conversations with the person, his or herself. And also, not everything is equally important. So again, a conversation with that person elicits also priorities or things that they find most important. So you could also make a distinction in that. And I think maybe your question came from the thing that I did, of course, with identifying subtype, living setting, and phase of the disease process. And that's also, I've done that also to create some sort of image about how complex needs are and how they can vary. But it is not the case, as I mentioned before, that you check off all those bullet points, but just a conversation with each other, that's always the starting point.
Thank you. Did you want to add anything, Suzanne?
Yes, I'm glad you answered that first, Maud, because I am also flummoxed about that. So as someone who was in clinical practice as well and has a background in that, I know how tricky it can be to try and deliver all of these things at once. And I think that's really why my work is geared towards looking at, well, how do we provide frameworks? And I know that there was one brought out by yourselves, Tessa, is it in collaboration with yourselves? There has been some frameworks suggested recently. In Scotland, that's not what we have. So we have specific services for young onset dementia or specific frameworks. But I think that constraining voice of professionals is going to be really, really important. So it's interesting that you asked that specific question because that is the question. That is the key question. And that's not one that I can answer just now, but that's one that, my future work is going to be looking towards providing some sort of guidance around, some sort of way of measuring whether we are managing to provide that would be useful.
Yes, wouldn't it just? Thank you so much. I'm going to move on to ask whether your research findings get escalated to in UK government to increase support for young onset dementia in some way, shape, or form. And if we make this really brief answer, then I can include another question as well. Anyone? Suzanne?
I can answer that. So I believe that very much the research literature is used to inform policy and strategy at government level. And I think that's why we have to be quite careful about the direction that the research is taking and how well defined things are in the research. But there is certainly an effort, particularly in Scotland, so I'm not as familiar with the UK as a whole, but there is, there are great people go to great lengths to have lived experience and to have current research and current best practice incorporated into policy and strategy. But I think there's something between policy and strategy that needs to be addressed, between research and policy and then implementation of that.
Yeah, thank you. What recommendations would you make for someone who wants to build a health literacy program to educate people around young onset? The link between age, life stage, specific conditions can be complex. Any recommendations?
Yeah, it's like a bit of an open door, of course, but to include the persons with their lived experience to inform your content and the main core of that program, but also I think different people. It's really important to not do it on your own, but to keep talking to people who are experiencing it from different perspectives. So also healthcare professionals and family members, and not only the persons living with young onset dementia. And you can dive deeper into that each time because every specific situation is different. But I think it all starts there because there you can see what do we actually need and what is actually important, and then you can build on top of that. But as I said before, it's a bit of an open door, so maybe Suzanne will come up with another answer. I don't know.
I don't really believe so. Maud, I don't believe I could come up with anything more directive than that, really, because I think a lot comes into it. So a lot comes into providing that kind of care and support, and it's not just to do with your intention, and it's not just to do with your understanding of the situation. It's also constrained by, the infrastructure, the surroundings, what you're able to provide. So I think that would definitely need to be on a case-by-case basis for, whoever was aiming to provide the service.
Thank you very much. One more, and this would need to be very brief. What do you think are the challenges specific for people with young onset when accessing support from primary care services after diagnosis? Just throw in a couple of thoughts on that, if you can.
Just to go back to what Leanne was saying, I think that people are still very much struggling to access support from care services in general, although, we, particularly in Scotland, we do have some specific services, but in terms of the way that these are set up geographically, it's not equal access across the board. It's probably very similar in other countries and other regions. I think it can be very, very tricky. And I think part of it is, that initial contact with primary services and that signposting, and doing something in that area where we're upskilling people in primary services who, generally speaking, so especially if we're talking about GP services and things, people are very, their focus is very widespread. They're very generalised in their knowledge, so they don't have specific knowledge around about young onset dementia. So I think at the moment in Scotland anyway, it's important that we get someone to people with specialist knowledge as soon as possible. And that's the role
Thank you.
Primary care.
Yes, thank you so much. I'm going to close it now. I'm going to say that we had to postpone our March webinar. So in fact, the next one is 19th of May, and we're going to tell you all about it. It's about autism and young onset dementia, and we'll tell you all about it in the March news. If you haven't joined up to the network and therefore don't receive the news, then do please join up. We would love you to be part of the network. Big thank you to Suzanne and Maud. That was really useful. It went by in a flash. We will be sharing everything, of course, in the follow-up email, and make sure that there's access to your publications as well. That's it, folks. Thank you so much.
Thank you.
Thanks. Thanks very much for attending as well, everybody.